sir.
Thank you, Bansi. I thank Dr. Shaukat Sadiqut for giving me this opportunity and to be in this beautiful city of Chennai once again. Um, Bansi, with your permission, I slightly changed the title and I have put it a little bit more emphatic and saying the international guidelines are not suitable for India. Uh, and one might ask right in the beginning, what is the reason for doing so? Well, it's my personal perception for a very long time. It is also as a result of discussion from the various key opinion leaders, Sadikot, Mohan, Ramchandran, Yajnik, everybody, at this point of time, and based on some of the data, which has been accruing for quite some time. I wouldn't say the data are extremely robust, but at this point of time, we should make some changes. We should think about it. Let's look at the international guidelines at this point of time. These are the 2015 international guidelines for management of hyperglycemia, and each step of therapy, first line therapy, second line or dual therapy, and third line therapy is based on a couple of principles, and these principles are depending on efficacy of the drug, hypoglycemia risk, weight changes, side effect, and cost. And as you can see, and this has been for a while now, that metformin remains number one drug, and people have been debating whether this is the correct decisions or not. Followed that, there are a number of options in the dual therapy. Sulfonylurea, still good for the country like us, where cost is a concern. Thiazolidinediones, now absorbed of many of the risk previously associated with it, and still continues to be an excellent drug, pioglitazone. DPP-4 inhibitors, now used widely, safe but costly. GLP-1 receptor agonist, good drugs, costly, injectable. And insulin, of course, always there is a fear of injection, although I would agree with Mohan that sometimes one needs to start with the insulin right in the beginning. And then subsequently triple drug therapy, where one can combine other drugs with a previously used drug, and then followed by insulin and in combination with GLP-1 receptor agonist or metformin. So how many people in this hall are actually convinced that this should be the algorithm for Indian population? All those who are very convinced about it, please raise your hands. I'm surprised that there's so few people who are convinced about whether this is the right algorithm. How many people are convinced that this is the correct algorithm for Indian population? Please raise your hand again. So I see 15 people. So largely most of you are with me at this point. So I'll move on to the various questions and doubts associated with this algorithm. Indians are different. And number of studies from Mohan's group, from Yajnik group, from Ramchandran's groups, and many other studies have proved that our bodies are different, our responses are different. For example, we are probably more obese, we have more body fat, we have more abdominal fat, and we have more insulin resistance. And this is one of the prime driver for multiple complications and even cardiovascular complications. Now, this is our recent article, Need for Ethnic-Specific Guidelines for Prevention, Diagnosis and Management of Type 2 Diabetes in South Asia. I have grouped together all the South Asian countries in one go because we share many of the features. And these things start from diagnosis and cutoff, obesity, abdominal obesity, and we have discussed about glycosylated hemoglobin, lipid cutoff, management, for example, C-reactive protein, lipoprotein little a, diet, physical activity, statin therapy, and complication, how to aggressively tackle complication. Aggression is the word as far as India is concerned. So these are some of the suggested possible ethnic-specific modification, not only in the management of hyperglycemia, but also in diagnosis, prevention, and in treatment of complications. Now, some effort has been made earlier. And you can see that there are consensus physical activity guidelines for Indian population, much more intensive than what has been given internationally, because our bodies need much more exercise than usual. And also the dietary guidelines. Our dietary guidelines are different. Our diets are different. And so our dietary guidelines are totally different from whatever one is eating or whatever one is doing as far as the rest of the countries are concerned. And also, clearly, obesity, lower cutoffs of obesity, and which have been now internationally accepted, abdominal obesity, and even metabolic syndrome. So this has been going on for some time, that we need ethnic-specific guidelines for everything, and that whatever has been initiated in the West, we should just not take it just like that, and we should have our own views and own modification. So these are the questions and doubts. Consider heterogeneity of our population. We know that people in South India and Chennai are different from the North India, and so are people in Manipur are different from Kashmir. Different phenotype. There are people in Manipur who are more muscular, or people in Chennai who have more abdominal fat, or North India more abdominal fat, and so on. We have different diets. Again, heterogeneity of diets, heterogeneity of cultures. India is like multiple countries, but we should take this heterogeneity in consideration. First line therapy. Is metformin okay for all? For example, let me give you an example. A patient with a BMI of 19.5, suffering from pulmonary tuberculosis, high fever, who is a known diabetic, lost weight, comes with 200 to 300 sugars. Should we give metformin to this person? Does the international guidelines say it in those very words, that these are different people? These are people who are specific to South Asian countries, who may suffer from tuberculosis, may suffer from malnutrition, may have different types of diabetes. It has not been addressed. What about treatment of non-obese or lean people? For example, BMI less than 25 for non-obese people, by BMI criteria. Should metformin be given or something else be given? Are these people have different characteristics? They are obese actually, although they have been called non-obese. Now, this is something we should consider. And what about the people who are lean, a BMI of 19 to 20 kg per meter square? We have seen everybody, all of us see such patients every day. And some portions of India, they are more. For example, Orissa, for example, Manipur or Kashmir. Those people who are labor intensive, they do a lot of exercise, still develop diabetes. They are lean. What about a patient with ketosis? Now, we associate ketosis with type 1 diabetes. What about type 2 diabetes with ketosis? Should metformin be the first choice? I don't think so. Treatment regimen for those with a very high blood glucose level. For example, let's say 250 fasting and 350 postprandial. Should only metformin be given? Should we not start something else right in the beginning? If we go by international guidance, we'll be stuck with a certain regimen, although they say it has to be individualized, but we need more options as far as these people are concerned. Second line therapy. For example, I fail to understand why alpha glucosidase inhibitors have not been given a place, and I have found a place in the footnote of every international guideline, while Japanese and Chinese always think that alpha glucosidase inhibitors are very important drugs for their population, and I'll come to this a little later. So let's look at lean and non-obese diabetic patient. Now, this is a seminal study by Mohan, and I don't think any other study has challenged this study in terms of number and the way it was performed. In this particular study, the way back it has been done, a little bit, these people have been classified a little bit differently. Lean, less than 18.5 kg per meter square. Ideal body weight in women up to 25, in men up to 27, which doesn't stand today, Mohan, that was quite some time back. And obese above that. And there are, you can say, a sizable number of people. Even at this point of time, 3.5% have a BMI of less than 18.5 kg per meter square. So the very lean diabetes, type 2 diabetes exist. And if we say take a BMI of say 20, less than 23, there will be 20 to 30%. Even in this particular study, although it is not given it in the data. Now, these lean patients have more severe, this is very interesting actually, and I think we have all learned from this particular study, more severe hyperglycemia, more severe retinopathy, neuropathy, nephropathy. So everything is more severe in these lean patients. Also, 50% are actually controlled on OHA. Now, these OHA, at that time, probably sulfonylurea. This was done a couple of years back. What about recent? No, this is the data from the same study, and you can see, fasting hyperglycemia much more, postprandial hyperglycemia much more, and so on. So these are people who have severe metabolic derangement, lean type 2 diabetes. What about recent data? Now, this is some of the recent data from the hilly areas of India. Less than 19 kg per meter square, 4%. Still, the same percentage exists, though the region is different. And 29% have complication of diabetes. So again, these people have a lot of complication right in the diagnosis. These are newly diagnosed patients. And their A1C is much more when they are having complications. So many of those who have uncontrolled diabetes, those lean patients, newly diagnosed, have complications. Now, this is our study done way back, almost 8-9 years back, and we published it. What we did, we took diabetic patients and looked at their body composition. And so this is the high waist circumference, high waist hip ratio. This is skin fold, sum of 4 skin fold. This is BMI more than 25 and high body fat. And this is a tertiary care center, All India Institute of Medical Sciences. Tertiary care center where, people come at secondary or tertiary stages. You can see very well that even here, people, almost 30 to 40% of, maybe more than that, have a BMI of less than 25. So then, not 40 to 60% are obese if we take BMI criteria, but we take a body fat criteria, only 10 to 30% remain obese. So there are non-obese patients coming to a tertiary care center. Now, this is our recent data, and what we have done is we have taken patients with type 2 diabetes mellitus and compared them with the non-diabetic controls. These all have BMI less than 25. We have done a detailed body composition study using MRI, MRS, ultrasound, DEXA, skin fold, everything. Now, this is just a part of the study. This is a detailed study, just a part of the study. Look at the total abdominal fat in patients with T2DM who are less than 25 versus non-diabetic control less than 25. BMI matched. 30% more total abdominal fat, almost 40% more, 30 to 35% more intra-abdominal fat, and the fatty liver. This is liver span is increased, and we have correlated with fatty liver. Fatty liver much more in diabetic patients. These are so-called non-obese diabetic patients. This is some of the images from these non-obese diabetic patients. This is the subcutaneous fat. This is the posterior subcutaneous fat. This is the intraperitoneal fat. This is the retroperitoneal. We don't want to bore you with these images, but the fact is that fat everywhere in these so-called non-obese people was high. So if we summarize these key points here, 20 to 30 patients of Indian patients who have diabetes have a BMI of less than 23. 10 to 20, if we take body fat as a standard, 10 to 20% have non-obese body fat. Around 5% they are very lean, less than 19, and especially those residing in rural hilly areas. But those who have less than 25 BMI have increased subcutaneous, intra-abdominal fat, and liver fat. All indicators of high insulin resistance. So what does that mean? Metformin is an apt drug for non-obese people, except probably in lean. Highly effective in this population because it is acting at the insulin resistance and all these metabolic derangements. Let's look at ketosis in patients with type 2 diabetes. Now, we know ketosis may occur in type 2 diabetes, severe infection, surgery, trauma, steroids, major interruption of treatment, and a very interesting entity which has been described from Japan, high intake of sugar-sweetened beverages. Those who are taking 10 colas per day, they develop this sort of diabetes and virus infection possibly. But what is interesting is some of the patients with type 2 diabetes are prone to ketosis without any of these things. And these have been described in various studies. Now, this is a study from neighboring country, Pakistan. These initial presentation with diabetic ketoacidosis was in type 2 diabetes, 14% presented. And most of them had precipitating factors and infection. On follow-up, 30 out of 45 remained on OHA. So, ketosis as presentation of type 2 diabetes is known. Many of them have precipitating factors, and many of them will remain on OHA on subsequent follow-up. But what about if there is no precipitating factor? This is one of the most elegant studies on this subject. Ketosis-prone type 2 diabetes mellitus, 10 years follow-up study from sub-Saharan Africa, and we have seen such patients, although no systematic study has been done as far as India is concerned. Now, these people divided these into 3 categories: type 2 diabetes, type 1 diabetes, and ketosis-prone type 2 diabetes. Now, these were anti-GAD and all antibodies negative. Type 2 diabetes, ketosis-prone, anti-GAD negative. Look at the BMI, high BMI in ketosis-prone type 2 diabetes. Their A1C was way too high. Their arterial pH at presentation of ketosis was lower than type 1 diabetic patient, and bicarbonate was lower. So they had presented with marked acidosis more than type 1 diabetes with ketosis. This is a peculiar type of presentation. And that subsequently their beta cell function improved. After treatment of ketosis, you see these are the people. This is the type 2 diabetes, this is the control, this is the C-peptide levels, this is the type 1 diabetes, this is the type 2 diabetes without ketosis. Now, these are the people with ketosis, initially low C-peptide, and jump up in the C-peptide equivalent to type 2 diabetes, subsequently more than that, and maintaining that, unless another episode of ketosis occurred. Similarly, see, their insulin sensitivity on follow-up improved. These are the control people. These are the insulin sensitive of these ketosis-prone type 2 diabetic patients, improved markedly after the treatment. So, what is the summary of this particular type of presentation? Strong male predominance, stronger family history, higher age and BMI, and more severe metabolic derangement than T1DM at presentation with ketosis. Remission is 76%. Intermittent ketosis and remissions. Preceding weight gain and hyperglycemia are the only risk factor for ketosis. And insulin sensitivity and C-peptide level improve markedly after remission, almost close to normal. So this is a particular entity we should take in account in the initial presentation of type 2 diabetes with ketosis, where different therapies may act, not metformin. So key points here. Ketosis may be present in type 2 diabetes in various situations. 5 to 15% may present initially with ketosis. A variety of ketosis-prone diabetes has been described in sub-Saharan Africa, also likely to be present in Indian population. And we have discussed some of the doubts in the first line therapy. What about the second line? What about acarpose has been discussed in the last 2 days. What I'll do is I'll only discuss pertinent points. Acarpose competitively inhibits alpha-glucosidase inhibitor at enterocyte brush border. Absorption of consumed carbohydrate is delayed, resulting in decreased postprandial hyperglycemia, and particularly suitable for Indian population because we have a mean carbohydrate intake of 64%. 55 to 60 is the upper limit, which we have written in the dietary guidelines. So much more than possibly other population. And also, we have marked postprandial hyperglycemia. Look at this particular study where number of regions of the world were compared, and India is right here, and this is the fasting, morning pre-meal, 2 hours post-meal, midday, 2 hours postprandial, 2 hours postprandial dinner. This is India. Look at the postprandial hyperglycemia. And we know that it is one of the strong risk factors for coronary artery disease. Indians have the highest postprandial meal glucose level as compared to any other population in the world. Acarbose, how does it behave as far as Indian population is concerned? This is a recent study, 12 weeks follow-up, short follow-up, decrease in fasting glucose by 38%, PP by 74, A1C by 1%, weight decreased by 1.4 kg, and waist circumference by 1.6 centimeters. Now, this is the study where metformin has been compared, not in Indian population, in Chinese population, with acarbose. And both have the results show almost similar. 784, acarbose versus metformin in normal, overweight and obese group, 48 weeks follow-up. Decrease in hemoglobin A1C proportion reaching less than 6.5, similar in both groups. And in overweight group, the metformin decreased fasting glucose better and acarbose decreased postprandial better. Similar decrease in the weight, BMI and waist circumference in 3 groups. Also, acarbose this is the meta-analysis, is shown to decrease insulin level more in Asian population as compared to the Caucasian population. And weight is also more, though statistically not significant. Now we know that adiponectin levels are very high. This is the comparative study, Asian population versus white, and you can see very well they are matched for BMI, body fat, etc. Adiponectin levels are low in Asian and very high in whites, meaning thereby marked insulin resistance as shown by rate of glucose disposal also. So adiponectin is a key for insulin resistance. What does acarbose do to adiponectin? It increases. This low adiponectin is increased after acarbose therapy. Another good point from acarbose. Also, it decreased the atherosclerosis associated membrane type 1 matrix metalloproteinase and the stiffness of the arteries. Also, way back, 13 years back, this study showed that acarbose increased GLP-1, published in a very reputed journal, American Journal of Physiology. So acarbose, after a mixed meal, increased GLP-1 levels. So this is an additional advantage of acarbose. So Indian patient, what is the key point? Acarbose suitable because of high postprandial hyperglycemia and high carbohydrate containing meals, targets PP insulin, adiponectin, weight, waist circumference, arterial stiffness, problem associated with Indian phenotype, and there is additional increase in GLP-1 level. So, is there a suitable algorithm for Indian population? This is for submission, debate, this is nothing final about it. This is the suitable algorithm. Primary determinant is BMI. Less than 20 BMI, those who don't have ketosis, major infections or major morbidity, possibly sulfonylurea, those who have all three in any BMI should go on to the insulin levels. 20 to 23, we know they are fat people actually, and they have a lot of abdominal obesity, where metformin could be useful or sulfonylurea can be used. Certainly more than 23, which is the threshold for overweight for Indian population, metformin is the drug of choice. What about if a second determinant, hemoglobin A1C more than 9% comes in, when the sugar is very high? If ketosis, infection, major morbidity is present, insulin therapy, no doubt about it. But if this is so, in any BMI, a dual therapy needs to be considered or insulin comes in again. Dual therapy, depending on the body composition and BMI characteristic, could be sulfonylurea, metformin, pioglitazone, and insulin if the sugar is too high. This is a major difference in step 1 of the ADA, ESDA algorithm and this algorithm. And second is very easy. We add acarbose with intermediate efficacy, with low hypoglycemia risk, with neutral or weight loss characteristic, but possibly the GI side effects are sometimes prohibitive, and a cost which is lower than GLP-1 agonist and SGLT2 inhibitors, and also DPP-4 analog. This is for debate, discussion, and we have discussed amongst ourselves in various fora, and we'll take it forward, and maybe it becomes algorithm for Indian population. Thank you so much.